Question 1. Topic: Radiation physics and dosimetry. In radiation therapy, the choice of beam energy significantly impacts dose distribution within the patient. When treating deep-seated tumors, such as prostate cancer, which of the following beam energy considerations is the most appropriate and why? A low-energy X-rays, G5010 kVp for better skin sparing. B. High-energy X-rays, G1518 MV to ensure deeper penetration with reduced surface dose. C. Electron beams to achieve uniform dose distribution within the tumor. D. Gamma rays due to their ability to scatter and reach deeper tissues effectively. Answer: B. High-energy X-rays, G1518 MV to ensure deeper penetration with reduced surface dose. Explanation: high-energy X-rays 1518 MV are ideal for deep-seated tumors like prostate cancer because they have higher penetration while reducing the entrance dose to the skin and superficial tissues. Low-energy X-rays 5010 kVp are primarily used for superficial treatment, e.g. skin cancers, and do not penetrate deep enough to treat tumors located in the pelvis. Electron beams have limited penetration depth and exhibit rapid dose fall-off, making them unsuitable for treating deep tumors. They are more commonly used for superficial tumors or areas where minimal penetration beyond certain depth is required. Gamma rays, such as those from cobalt-60, have fixed energy of around 1.25 MeV. Can be used for treatment, but they are not as flexible or efficient as linear accelerator-generated X-rays for deep-seated tumors. Relevant guidelines: Opatija 51 Protocol for Beam Calibration, NICRU Report 50 and 62 on dose prescription and reporting in radiation therapy. Question 2. Topic: Quality assurance and patient safety in radiation therapy. Scenario-based. Dr. Patel, radiation oncologist, is reviewing the treatment plan for patient undergoing intensity-modulated radiation therapy for head and neck cancer. The dosimetrist, Sarah, notices that the plan includes high dose to the spinal cord exceeding the established dose constraint. However, the radiation oncologist has already approved the plan. What should Sarah do in this situation? A. Proceed with the treatment as it has been approved by the physician. B. Discuss the concern with the medical physicist and collaboratively reassess the dose distribution. C. Manually adjust the plan to reduce the spinal cord dose without informing the physician. D. Document the issue but avoid raising concerns to avoid conflict with the radiation oncologist. Answer: B. Discuss the concern with the medical physicist and collaboratively reassess the dose distribution. Explanation: patient safety and adherence to dose constraints are critical in radiation therapy. The Radiation Therapy Oncology Group, RTOG, and Quantec guidelines recommend strict spinal cord dose limits to prevent radiation myelopathy. The dosimetrist has an ethical and professional responsibility to ensure safe and effective treatment. Ignoring an overdose can lead to severe complications, including permanent spinal cord damage. Option A is incorrect because blindly proceeding with treatment can compromise patient safety. Option C is incorrect because the dosimetrist cannot modify the plan without physician approval. Option D is incorrect as not addressing the concern can lead to preventable radiation toxicity. Relevant guidelines: Quantec dose constraints, Opatija 100 for risk analysis in radiation therapy, and professional ethics outlined by them. D. Question 3. Topic: Treatment planning principles and techniques during the optimization of an intensity-modulated radiation therapy plan for a patient with a brain tumor. Which of the following factors is the most crucial when ensuring adequate tumor coverage while minimizing dose to organs at risk? A. Using only 2 opposing beams to simplify the treatment plan. B. Maximizing monitor units moved to increase dose conformity. C. Employing inverse planning with dose constraints for ores and target volume. D. Ignoring dose volume histogram EHS and focusing solely on target dose coverage. Answer: C. Employing inverse planning with dose constraints for ores and target volume. Explanation: Inverse planning is a core component of IMETWeb. The treatment planning system TPS optimizes dose distribution based on predefined constraints for both the target and surrounding organs. Option A is incorrect because using only 2 opposing beams limits dose sculpting capabilities, potentially leading to suboptimal tumor coverage and higher ore exposure. Option B is incorrect as increasing monitor units does not necessarily improve dose conformity but can increase radiation exposure to normal tissues. Option D is incorrect since dose volume histogram EHS are critical tools in evaluating plan quality, ensuring that the prescribed dose is delivered effectively while protecting healthy tissues. Relevant guidelines. Arpeteja 119 for EMIT commissioning, ICRU reports 50 and 62 for target volume delineation, and Quantec dose constraints for ORS. Question 4. Topic: brachytherapy and dose calculation. A patient with locally advanced cervical cancer is scheduled to undergo high-dose rate HDR brachytherapy following external beam radiation therapy. The prescribed brachytherapy dose is 7 Gi per fraction to 0.8, delivered in 4 fractions. During a quality assurance check, the medical physicist notices that the dwell time for one of the catheters appears longer than leading to an unintended increase in dose to the rectum beyond the Quantec recommended tolerance level. As the radiation oncologist, what is the best course of action to address this issue while maintaining optimal tumor coverage? A. Proceed with the current treatment plan since the primary goal is to ensure that the prescribed dose is delivered to point A, regardless of rectal dose. B. Re-optimize the dwell times and catheter loading pattern to reduce rectal dose while ensuring adequate target coverage. C. Discontinue brachytherapy and rely only on external beam radiation therapy for local tumor control. D. Manually adjust the treatment parameters on the after without recalculating the dose distribution. Answer. B. Re-optimize the dwell times and catheter loading pattern to reduce rectal dose while ensuring adequate target coverage. Explanation: HDR brachytherapy requires precise dose delivery, and exceeding organ at risk or dose constraints can lead to severe toxicities such as rectal ulceration and fistulas. Option A is incorrect because ignoring rectal dose constraints can lead to significant late toxicity. Option C is incorrect because brachytherapy plays a crucial role in dose escalation for cervical cancer, and omitting it would reduce the probability of local control. Option D is incorrect since modifying parameters without recalculating the dose could result in unintended dose distributions. Relevant guidelines: ABS American Brachytherapy Society Cervical Cancer Brachytherapy Guidelines, Quantec dose constraints for rectum, 75 Gi ICRU 89 recommendations. Question 5. Topic: radiation protection and shielding design. A new linear accelerator is being installed in a radiation therapy facility. The beam energy is 18 MV and the workload is estimated to be 500 Gi per week. The facility is adjacent to a pediatric ward requiring stringent radiation protection measures. Which of the following is the most important factor when designing primary and secondary shielding barriers? A. Primary barrier thickness should be based on the highest beam energy used and the expected workload. B. Secondary barriers should only be considered if the walls are thin and may allow scatter radiation to escape. C. The use of 18 MV beams negates the need for neutron shielding, as neutrons are not a concern in radiotherapy. D. Lead shielding alone is sufficient to protect against all types of radiation exposure in megavoltage therapy. Answer. A. Primary barrier thickness should be based on the highest beam energy used and the expected workload. Explanation: primary barriers protect against direct beam radiation and must be designed based on beam energy, workload, and occupancy of adjacent areas. Secondary barriers account for scatter and leakage radiation and are always required, not just when walls are thin. Option C is incorrect because 18 MV beams generate photoneutrons, requiring neutron shielding, typically borated polyethylene. Option D is incorrect since lead is not effective against neutron radiation. Concrete is typically used for shielding high-energy photon and neutron radiation. Relevant guidelines: SOP Report No. 151, Arpeteja 108, and IA Radiation Protection Guidelines. Question 6. Topic: image-guided radiation therapy. IGAT Radiation Oncology Department is transitioning from weekly pupil imaging to daily cone beam computed tomography (ET) for head and neck cancer patients receiving IMITI. What is the primary advantage of this transition in terms of treatment accuracy and patient outcomes? AET provides real-time tumor tracking, eliminating the need for any additional setup verification steps. B. Dale EET reduces radiation dose to the patient compared to weekly portal imaging. CET approves setup accuracy and allows adaptive treatment planning based on anatomical changes. DET is superior in all scenarios and should replace all other forms of IGAT regardless of tumor site. Answer. CCET approves setup accuracy and allows adaptive treatment planning based on anatomical changes. Explanation. Daily ET enables precise patient positioning and adaptation of treatment based on tumor and normal tissue changes over time. Option A is incorrect because ET does not provide real-time tracking like fiducial-based tracking for prostate cancer. Option B is incorrect as CET typically delivers a higher radiation dose per image compared to weekly TWAD portal imaging. Option D is incorrect because different IGIT modalities have specific use cases, e.g. fiducial tracking for prostate MRI guide RT for soft tissue tumors. Relevant guidelines: OPTG 179 for IGIT, ASTRO guidelines on adaptive radiation therapy. Question 7. Topic: Proton therapy, relative biological effectiveness and treatment planning in proton therapy. The concept of relative biological effectiveness, RBE, is critical for treatment planning. The standard RBE for proton therapy is assumed to be a 1.0 as protons interact in the same manner as megavoltage X-rays. B 1.1, meaning protons cause slightly more biological damage. Photons. C 2.5, due to the high LET characteristics of protons in the entrance region. D variable, depending on the tissue type, linear energy transfer, LET, and dose per fraction. Answer: B 1.1, meaning protons cause slightly more biological damage than photons. Explanation: proton therapy is typically planned assuming an RBE of 1.1 relative to megavoltage X-rays. However, RBE can vary depending on LET tissue type and dose per fraction, particularly in the distal edge of the Bragg peak. Option D is partially correct, but not the standard assumption in clinical treatment planning. Relevant guidelines: ICRU Report 78, OPTG 256 on proton therapy RBE considerations. Question 8. Topic: Stereotactic body radiation therapy. SRT. The SRT lung cancer treatment, which of the following dose fractionation schemes is most commonly used and supported by clinical evidence to achieve high tumor control while minimizing normal tissue toxicity? A. 60 Gy in 30 fractions. B. 45 Gy in 25 fractions. C. 50 Gy in 5 fractions. D. 30 Gy in 3 fractions. Answer: C. 50 Gy in 5 fractions. Explanation: SRT for lung cancer relies on hypofractionation to deliver ablative doses with high tumor control probability TCP. 50 Gy in 5 fractions is a common regimen supported by RTOG protocols balancing tumor control and normal tissue constraints. Relevant guidelines: RTOG 0915 are SRT guidelines. Question 9. Topic: Adaptive radiation therapy. A patient undergoing chemoradiation for oropharyngeal cancer experiences significant weight loss and tumor shrinkage by week 4 of treatment. The best strategy to maintain treatment accuracy is A. Continue the original plan without changes. B. Resimulate and generate an adaptive plan to account for anatomical changes. C. Increase the dose to compensate for tumor shrinkage. D. Reduce treatment margins without resimulation. Answer: B. Resimulate and generate an adaptive plan to account for anatomical changes. Explanation: Adaptive radiation therapy ensures accurate dose delivery by updating the treatment plan based on anatomical changes. Ignoring changes can lead to underdosing the tumor or overdosing normal tissues. Relevant guidelines: OPTG 132 for deformable image registration, ASTRO guidelines on UT. Question 10. Topic: Intensity modulated radiation therapy. IMiT optimization. Radiation oncology department is treating patient with locally advanced nasopharyngeal carcinoma using IMiT. The prescribed dose is 70 Gy to the gross tumor volume GTV, 63 Gy to the high-risk clinical target volume ETV, and 56 Gy to the low-risk CTV, delivered in 33 fractions. During plan evaluation, the dose volume histogram DEH shows that the spinal cord received maximum dose of 48 Gy, slightly exceeding the constraint of 45 Gy. Additionally, the parotid glands receive mean doses of 28 Gy and 31 Gy. What is the best course of action to optimize the IMiT plan while maintaining target coverage? A. Proceed with the plan since the spinal cord dose is only slightly above the constraint and parotid dose constraints are acceptable. B. Reduce the prescribed dose to all target volumes to ensure spinal cord dose remains within the limit. C. Use additional optimization constraints and rerun inverse planning to reduce spinal cord dose while maintaining target coverage. D. Modify beam angles manually without re-optimizing the plan. Answer: C. Use additional optimization constraints and rerun inverse planning to reduce spinal cord dose while maintaining target coverage. Explanation: IMIT allows dose shaping, and excessive spinal cord dose should be addressed using additional optimization constraints. Option A is incorrect because exceeding spinal cord constraints can lead to radiation myelopathy. Option B is incorrect because reducing dose to all target volumes would compromise tumor control. Option D is incorrect because modifying beam angles alone does not guarantee optimal dose redistribution. Relevant guidelines: OPTIGA 119 ATOG 0225 for NPC treatment planning. Question 11. Topic: Stereotactic radiosurgery. SRS for brain metastases. 58-year-old patient with non-small cell lung cancer SLSA, presents with single 2.5 cm brain metastases in the right frontal lobe. The Multidisciplinary Tumor Board recommends stereotactic radiosurgery SRS with single fraction dose of 20 Gi. What are the key considerations when planning this treatment? A. Minimizing dose to surrounding normal brain tissue while ensuring at least 99% of the target volume receives the prescribed dose. B. Prescribing the dose to the tumor center rather than to an isodose line to maximize tumor control. C. Using standard 3-field 3-conformal technique instead of non-coplanar arcs to simplify treatment delivery. D. Treating the entire brain with whole brain radiation therapy and SRS for maximum local control. Answer: A. Minimizing dose to surrounding normal brain tissue while ensuring at least 99% of the target volume receives the prescribed dose. Explanation: SRS requires highly conformal dose distribution with steep dose fall-off to spare normal brain tissue. Option B is incorrect because SRS doses are typically prescribed to an isodose line e.g. 80% rather than tumor center. Option C is incorrect since non-coplanar VMAT arcs or multiple static beams are preferred for SRS slanning. Option D is incorrect. BRI is not routinely given for single metastases due to neurocognitive side effects. Relevant guidelines: ORI guidelines or TOG 9005 dose constraints. Question 12. Topic: Total body irradiation. TBI for hematopoietic stem cell transplantation. Patient with acute myeloid leukemia or ME is scheduled for total body irradiation TBI as part of myeloablative conditioning regimen before hematopoietic stem cell transplantation. The prescribed dose is 12 Gi in 6 fractions over 3 days. Which of the following is the most critical consideration in planning and delivering TBI? A. Ensuring uniform dose distribution throughout the entire body while minimizing lung dose. B. Using single anterior-posterior beam to simplify treatment delivery. C. Delivering the entire dose in single fraction to reduce treatment time. D. Avoiding any compensators or bolus materials to maintain simple technique. Answer: A. Ensuring uniform dose distribution throughout the entire body while minimizing lung dose. Explanation: TBI requires homogeneous dose coverage with lung shielding to reduce the risk of radiation pneumonitis. Option B is incorrect because multiple techniques lateral or helical tomotherapy are used for dose uniformity. Option C is incorrect as fractionated TBI e.g. 12 Gi in 6 fractions reduces toxicity compared to single fraction TBI. Option D is incorrect since compensators are often used to ensure dose uniformity in different body regions. Relevant guidelines: ARROW TBI Guidelines, OPTIGA 29. Question 13. Topic: Brachytherapy. Prostate LDR seed implantation. 67-year-old patient with low-risk prostate cancer is undergoing permanent low-dose rate LDR brachytherapy with R125 seeds. Post-implant dosimetry reveals that the D dose covering 90% of the prostate volume is 115% of the prescribed dose. How should this dosimetry result be interpreted? A. The implant provides adequate coverage, but the risk of urinary toxicity should be evaluated. B. The implant is inadequate and additional external beam radiation therapy is required. C. The implant is suboptimal and the patient should undergo repeat implantation. D. The dose is too high and some seeds should be removed immediately. Answer: A. The implant provides adequate coverage, but the risk of urinary toxicity should be evaluated. Explanation: D values between 100% and 130% are typically acceptable, but higher doses increase urinary toxicity risks. Option B is incorrect since a DOE 115% suggests good implant quality. Option C is incorrect as repeat implantation is unnecessary. Option D is incorrect because seed removal is not a standard correction method. The relevant guidelines: APS Prostate Brachytherapy Guidelines. Question 14. Topic: Pediatric radiation therapy. Medulloblastoma. 5-year-old patient is diagnosed with medulloblastoma and requires craniospinal irradiation (CSI) followed by posterior fossa boost. What is the most critical aspect of treatment planning for this patient? A. Ensuring adequate spinal cord coverage while minimizing dose to the heart and lungs. B. Using whole brain radiation instead of CSI to avoid spinal toxicity. C. Treating the entire posterior fossa with uniform dose regardless of tumor location. D. Using photon therapy exclusively, as proton therapy provides no significant advantage. Answer: A. Ensuring adequate spinal cord coverage while minimizing dose to the heart and lungs. Explanation: CSI requires precise junction matching and lung dose minimization to reduce long-term toxicities. Option B is incorrect, as medulloblastoma spreads through CSF, requiring full neuraxis coverage. Option C is incorrect because focal posterior fossa boosts are now preferred over whole posterior fossa boosts. Option D is incorrect, as proton therapy significantly reduces dose to normal tissues. Relevant guidelines: ELG, Pediatric CNS Tumor Guidelines. Question 15. Topic: Adaptive radiation therapy. Art in head and neck cancer. Patient with locally advanced oropharyngeal cancer is undergoing intensity modulated radiation therapy IMIT with total dose of 70 Gy in 35 fractions. After 4 weeks of treatment, significant reduction in tumor volume is observed on CNINBA EET, leading to concerns about changes in dose distribution. What is the best approach to ensure optimal treatment delivery? A. Continue with the current treatment plan since the initial setup was robust enough to account for anatomical changes. B. Perform an adaptive replan to adjust the dose distribution based on the new anatomy. C. Increase the total dose to compensate for any potential underdosing caused by anatomical changes. D. Switch to 3 conformal technique to simplify treatment delivery. Answer: B. Perform an adaptive replan to adjust the dose distribution based on the new anatomy. Explanation: ART is beneficial for head and neck cancers due to significant anatomical changes during treatment. Option A is incorrect because significant tumor shrinkage can alter dose coverage. Option C is incorrect, as dose escalation without planning adjustments can increase toxicity. Option D is incorrect, since IMIT provides superior conformality compared to 3 conformal techniques. Relevant guidelines: Upper 132 Astro Guidelines on UT. Question 16. Topic: Stereotactic body radiation therapy. SRT for lung cancer. Patient with stage I non-small cell lung cancer (SLCs). Plan for SRT with dose of 54 Gy in 3 fractions. However, the tumor is located within 1 centimeter of the proximal bronchial tree. What is the most appropriate adjustment to the SRT plan? A. Proceed with the planned dose and fractionation. SRT is highly effective for early stage SLC. B. Reduce the fraction dose and increase the number of fractions to minimize the risk of toxicity. C. Use larger PTV margin to ensure coverage, even if it increases dose to critical structures. D. Switch to conventional fractionation with 60 Gy in 30 fractions. Answer: B. Reduce the fraction dose and increase the number of fractions to minimize the risk of toxicity. Explanation: Tumors near the proximal bronchial tree have increased risk of toxicity with high-dose SRT. Option A is incorrect because dose modifications are needed for central tumors. Option C is incorrect, as larger margins increase toxicity without added benefit. Option D is incorrect. CIS-RT is still preferred over conventional fractionation for early stage SLC. Relevant guidelines: RTOG 0813 dose constraints for central lung tumors. Question 17. Topic: MRI-guided radiation therapy. RT for pancreatic cancer. Patient with locally advanced pancreatic cancer is undergoing a guided adaptive radiation therapy. During mid-treatment MRI, significant interfraction motion of the tumor is observed due to respiratory changes. What strategy should be employed to ensure accurate dose delivery? A. Use daily adaptive replanning to account for anatomical variations. B. Continue with the original plan, as minor shifts are expected in pancreatic tumors. C. Increase PTV margins to compensate for motion without adaptive planning. D. Use fluoroscopy instead of MRI to monitor motion during treatment. Answer: A. Use daily adaptive replanning to account for anatomical variations. Explanation: T enables online adaptation to anatomical and respiratory variations. Option B is incorrect, as ignoring motion may lead to underdosing the tumor. Option C is incorrect since larger PTV margins increase dose to normal tissue. Option D is incorrect as MRI provides superior soft tissue contrast compared to fluoroscopy. Relevant guidelines. Upper EG 375. Question 18. Topic: brachytherapy. Cervical cancer. Patient with FIGO stage IB. Cervical cancer is receiving external beam radiation therapy followed by high-dose RET HDR brachytherapy. The prescribed dose is 28 Gi and 4 fractions to point A. What is the primary dosimetric goal for HDR brachytherapy in this case? A. Ensuring optimal coverage of the high-risk clinical target volume (EIE) while minimizing dose to ORS. B. Delivering uniform dose to the entire uterus and pelvic lymph nodes. C. Prescribing dose to point B instead of point to improve normal tissue sparing. D. Avoiding dose escalation even if tumor response is suboptimal. Answer: A. Ensuring optimal coverage of the high-risk clinical target volume (AOTVA) while minimizing dose to ORS. Explanation: HDR brachytherapy should balance tumor coverage with organ at risk or sparing. Option B is incorrect because whole uterus irradiation is not needed in brachytherapy. Option C is incorrect since point A remains the standard reference for dose prescription. Option D is incorrect as adaptive dose escalation may improve local control. Relevant guidelines. Check extra recommendations. Question 19. Topic: pediatric radiation therapy. Proton therapy for ependymoma. 4-year-old child with posterior fossa ependymoma is undergoing post-operative proton therapy. What is the primary advantage of proton therapy in this setting? A. Reduced radiation dose to surrounding normal tissues, minimizing late effects. B. High dose delivery compared to photon therapy for increased tumor control. C. Shorter overall treatment time compared to conventional photon therapy. D. Lower treatment cost compared to MET. Answer: A. Reduced radiation dose to surrounding normal tissues, minimizing late effects. Explanation: proton therapy has superior normal tissue sparing due to the Bragg peak effect. Option B is incorrect as proton and photon therapy have similar tumor control rates. Option C is incorrect since fractionation is similar in both modalities. Option D is incorrect as proton therapy is more expensive than IMRAT. Relevant guidelines. Astra Pediatric CNS Tumor Guidelines. Question 20. Topic: reirradiation. Head and neck cancer. Patient previously treated with 70 Gi for laryngeal cancer presents with recurrent tumor in the same area. What is the key consideration for reirradiation? A. Balancing tumor control with the risk of late toxicity. B. Using the same dose and fractionation as the initial treatment. C. Avoiding reirradiation entirely due to high toxicity risks. D. Treating only with systemic therapy to avoid radiation toxicity. Answer: A. Balancing tumor control with the risk of late toxicity. Explanation: reirradiation is feasible but requires careful dose constraints to minimize toxicity. Option B is incorrect because previous dose constraints must be considered. Option C is incorrect as reirradiation can be effective with modern techniques. Option D is incorrect since systemic therapy alone is often insufficient for local control. Relevant guidelines. Astra Guidelines on Reirradiation. Question 21. Topic: flash radiotherapy. Preclinical and clinical implications. Flash radiotherapy is an emerging technique that delivers ultra-high dose rates, 40 Gs, and has demonstrated reduced normal tissue toxicity in preclinical studies. Patient with superficial skin lesion is enrolled in clinical trial evaluating the safety and efficacy of flash therapy. What is the most significant potential benefit of flash radiotherapy compared to conventional photon therapy? A. Increased DNA damage in tumor cells due to ultra-high dose rate delivery. B. Reduced damage to surrounding normal tissues while maintaining tumor control. C. Elimination of the need for immobilization due to rapid dose delivery. D. Lower cost and increased accessibility compared to conventional radiotherapy. Answer: B. Reduced damage to surrounding normal tissues while maintaining tumor control. Explanation: flash radiotherapy has shown a flash effect sparing normal tissues while maintaining tumor control. Option A is incorrect because DNA damage mechanisms are not significantly different from conventional radiotherapy. Option C is incorrect as patient immobilization is still required for precise dose delivery. Option D is incorrect since flash therapy requires specialized equipment, making it currently more expensive. Relevant guidelines. Ongoing clinical trials and Astra updates on flash art. Question 22. Topic: Proton therapy for skull-based tumors. A 50-year-old patient with a clival chordoma is being considered for proton therapy. Given the tumor's location near critical structures like the brainstem and optic nerves, what is the primary reason proton therapy is preferred over conventional photon therapy? A. Proton therapy provides better tumor control compared to photon therapy. B. Proton therapy minimizes dose to surrounding critical structures due to the Bragg peak effect. C. Proton therapy allows for shorter overall treatment course. D. Proton therapy is less expensive than IMET. Answer: B. Proton therapy minimizes dose to surrounding critical structures due to the Bragg peak effect. Explanation: the Bragg peak effect allows protons to deposit maximum energy at the tumor site while sparing normal tissues. Option A is incorrect since tumor control rates for chordomas are similar for both modalities. Option C is incorrect as fractionation schedules are similar. Option D is incorrect because proton therapy is typically more expensive than IMA. Relevant guidelines. Astro guidelines on proton therapy for skull-based tumors. Question 23. Topic: ARS for brain metastases. Dose constraints. Patient with forebrain metastases is scheduled for stereotactic radiosurgery SRS using single fraction. What is the primary consideration when determining the dose for each metastases? A. Total intracranial tumor burden and proximity to critical structures. B. Delivering the highest possible dose to improve tumor control. C. Using whole brain radiotherapy in conjunction with SRS for better coverage. D. Treating only the largest lesion to reduce toxicity. Answer: 8. Total intracranial tumor burden and proximity to critical structures. Explanation: dose selection depends on lesion size, number of metastases, and proximity to organs at risk cause. Option B is incorrect as excessive dose can increase neurotoxicity. Option C is incorrect since SRS alone is preferred for patients with limited metastases. Option D is incorrect because all visible metastases should be treated if feasible. Relevant guidelines: SEN and Astro guidelines on SRS for brain metastases. Question 24. Topic: cardiac sparing in left-sided breast cancer. A 45-year-old woman with left-sided breast cancer is scheduled for whole breast radiation therapy following lumpectomy. What technique can be used to minimize radiation dose to the heart? A. Deep inspiration, breath hold, DIB. B. Increasing the total dose while reducing fraction size. C. Using electron therapy instead of photon therapy. D. Avoiding regional nodal irradiation. Answer: 8. Deep inspiration, breath hold, DIB. Explanation: DIB increases the distance between the heart and chest wall, reducing cardiac dose. Option B is incorrect as hypofractionation does not necessarily reduce heart dose. Option C is incorrect since electron therapy is not suitable for whole breast radiation. Option D is incorrect because nodal irradiation should not be omitted if clinically indicated. Relevant guidelines: Astro guidelines on cardiac sparing in breast. Question 25. Topic: SIB in head and neck cancer. A patient with stage-owned oropharyngeal cancer is receiving concurrent chemoradiation with an integrated boost SIB technique. What is the main advantage of SIB in head and neck cancer? A. Reduces treatment time while improving tumor dose conformity. B. Allows higher dose escalation to elective lymph nodes. C. Minimizes need for concurrent chemotherapy. D. Eliminates the need for daily imaging. Answer: A. Reduces treatment time while improving tumor dose conformity. Explanation: SIB enables differential dosing within a single plan, improving tumor control and reducing treatment duration. Option B is incorrect since elective lymph nodes receive standard doses. Option C is incorrect because concurrent chemotherapy is still needed. Option D is incorrect since daily imaging remains essential. Relevant guidelines: RTUG protocols on SIB. Question 26. Topic: particle therapy for pediatric patients. What is the most significant benefit of proton therapy for pediatric patients compared to photon therapy? A. Reduced late effects due to superior normal tissue sparing. B. Higher overall survival compared to photon therapy. C. Short treatment time per session. D. Less need for anesthesia due to faster delivery. Answer: A. Reduced late effects due to superior normal tissue sparing. Explanation: proton therapy minimizes secondary malignancies and developmental toxicity in pediatric patients. Option B is incorrect as survival depends on disease biology, not just modality. Options C and D are incorrect since treatment times are similar. Irrelevant guidelines. Oppum and Astra recommendations for pediatric proton therapy. Question 27. Topic: Adaptive radiation therapy for bladder cancer. A patient with muscle-invasive bladder cancer is undergoing radiation therapy. What is the primary advantage of adaptive radiation therapy in this setting? A. Compensating for daily bladder volume changes to ensure consistent dose coverage. B. Reducing total treatment time by escalating dose per fraction. C. Eliminating the need for concurrent chemotherapy. D. Avoiding the use of image guidance. Answer: A. Compensating for daily bladder volume changes to ensure consistent dose coverage. Explanation: bladder volume changes daily, making ARC crucial for accurate dosing. Option B is incorrect since hypofractionation is not the primary goal. Option C is incorrect as chemotherapy is essential for definitive treatment. Option D is incorrect since image guidance is critical. Relevant guidelines. Estra recommendations for ARC in bladder cancer. Question 20. Topic: Reirradiation strategies in head and neck cancer. A 62-year-old male with a history of TID of HEV negative squamous cell carcinoma of the oropharynx was treated with definitive chemoradiation 70 Gi in 35 fractions 2 years ago. He now presents with a local recurrence confined to the primary site without distant metastases. His tumor board recommends reirradiation. Weighs them. Critical consideration when planning reirradiation for this patient: A. Cumulative radiation dose to critical structures, particularly the spinal cord and brainstem. B. Using the same fractionation schedule as the initial treatment to maximize tumor control. C. Omitting concurrent chemotherapy to minimize toxicity. D. Switching to photon therapy instead of proton therapy for better dose homogeneity. Answer: A. Cumulative radiation dose to critical structures, particularly the spinal cord and brainstem. Explanation: reirradiation carries a high risk of toxicity, making dose constraints to organs at risk cause crucial. Option B is incorrect because fractionation often needs modification. G. Hypofractionation or hyperfractionation. Option C is incorrect as concurrent chemotherapy may still be necessary depending on tumor characteristics. Option D is incorrect since proton therapy may be advantageous in reducing normal tissue exposure. Relevant guidelines. ASTRO and NCCN guidelines on reirradiation in head and neck cancer. Question 29. Topic: Stereotactic body radiotherapy SRT for oligometastatic lung cancer. A 55-year-old patient with a history of TID to lung cancer treated with surgery and adjuvant chemotherapy 3 years ago now presents with a solitary 2.5 centimeters lung metastases in the right upper lobe, confirmed by PET-CT. The patient has good performance status ECOG 0 and no other metastasis. Disease is detected. What is the most appropriate radiotherapy approach for this patient? A. Stereotactic body radiotherapy SRT with a high ablative dose to the lung metastases. B. Whole lung radiation therapy to prevent further metastases. C. Conventional fractionated radiation therapy. G. 60 Gi in 30 fractions. D. Deferring radiotherapy in favor of immediate systemic therapy. Answer: A. Stereotactic body radiotherapy SRT with a high ablative dose to the lung metastases. Explanation: SRT is the preferred approach for oligometastatic lung disease, providing high tumor control while sparing normal lung tissue. Option B is incorrect because whole lung radiation is not appropriate for a solitary metastases. Option C is incorrect since conventional RT is less effective and more toxic in this setting. Option D is incorrect because local control of oligometastatic disease is beneficial. Relevant guidelines. ASTRO and ESTRA recommendation on SRT for oligometastatic disease. Question 30. Topic: MRI-guided adaptive radiation therapy. A 48-year-old female with locally advanced cervical cancer, FIGO stage IB, is undergoing definitive chemoradiation. Due to significant tumor regression during treatment, the radiation oncology team is considering an MRI-guided adaptive radiation therapy approach. What is the primary advantage of MRI-guided adaptive radiation therapy (MRGA) in this setting? A. Allows real-time tumor tracking and adaptive planning to account for tumor regression and organ motion. B. Eliminates the need for image-guided brachytherapy. C. Reduces overall treatment time compared to standard external beam radiation therapy. D. Avoids the need for concurrent chemotherapy. Answer: A. Allows real-time tumor tracking and adaptive planning to account for tumor regression and organ motion. Explanation. MARGART enables daily adaptive planning, optimizing dose to the tumor while sparing normal tissues. Option B is incorrect because image-guided brachytherapy remains a critical component of treatment. Option C is incorrect as MARGART does not necessarily shorten treatment duration. Option D is incorrect since concurrent chemotherapy remains standard of care. Relevant guidelines: Absen Estra recommendations and MRI guide RT for cervical cancer.